Hello, I'm Lynn Doyle. Thank you for joining us here on Meet the Doctors, where each week we look at important health news, medical breakthroughs, and alternative therapies, and we tell you how they may impact you and your family. We explore the facts so that you can make educated decisions because we want to empower you to take charge of your own well-being. Last week, we said goodbye to yet another comedy legend, this time 81-year-old Joan Rivers.
So I would rather work and live the way I live and have a wonderful time.
She died during an outpatient procedure. Now, it's not clear what caused her death yet, but it certainly has raised safety concerns and questions about elderly patients who are facing surgery and what they should be asking their doctors. Today, we'll be joined by an anesthesiologist and a gastroenterologist to talk about Rivers' tragic death and whether it could have been avoided. Then later, a TV exclusive here on Newsmax with a doctor whose at-home test may tell you if you're at risk for Alzheimer's. And of course, we'll have our panel of doctors to answer your email questions. But first, let's make the news rounds. Women of Ashkenazi Jewish descent who tested positive for cancer-causing genetic mutations called BRCA1 and BRCA2 during random screenings have high rates of breast and ovarian cancer even when they have no family history of the disease. These new findings recommend that all Ashkenazi Jewish women be tested early and routinely. A new cancer-fighting drug for melanoma that appears to work better than chemotherapy and other traditional treatments has just been fast-tracked by the FDA. The pharmaceutical powerhouse Merck & Company's new drug, Keytruda, treats advanced cases of skin cancer which have spread or which are inoperable. It works with your immune system to seek out and destroy cancer cells, and the side effects apparently are not as severe as those resulting from traditional chemotherapy, things like hair loss and nausea. The drug is in the first of a class of what's called anti-PD-1 or anti-immune drugs to be approved here in the U.S. It's hard to believe, but it's almost time to get your seasonal flu shot. Now, 2 studies show that a single-dose injection of a new drug can alleviate flu symptoms. In one study, 427 adults were given an injection of peramivir or a placebo within 48 hours of the start of the flu symptoms. Now, patients who received the new drug were symptom and fever-free up to 24 hours sooner than those taking just the placebo. They were also less contagious over the first 2 days, so that's really good news for us. Each year in the U.S. alone, flu cases cause more than 200,000 hospitalizations and 36,000 deaths. That is definitely good news as the flu season approaches. And here's a breath of good news. Smoking is now banned in 8 out of 10 U.S. homes. That's nearly twice as many as 2 decades ago. The Centers for Disease Control and Prevention found smoking is even forbidden in nearly half of the homes where an adult smoker lives. The smoking rate fell from 25% in 1993 to 19% in 2011. Utah led the way with 84%, while Kentucky and West Virginia tanked with both under 70%. Secondhand smoke causes an estimated 41,000 deaths among non-smoking adults each year through heart disease and lung cancer. Now, it's not just an apple a day that keeps the doctor away. A 7-year study involving nearly 500,000 people in China found that eating any kind of piece of fruit daily significantly cuts the risk of developing heart disease by up to a whopping 40%. Eating fruit also lowers blood pressure, that study concluded. And here's more food for thought. Action-packed movies tend to make you eat more junk food than if you watch, say, a Charlie Rose interview on PBS. A quirky new study examined why people tended to eat more while watching TV and whether the type of programming actually made a difference. Researchers at Cornell University gave snacks to 97 undergraduate students and then split them into 3 groups. The first group watched the 2005 Michael Bay blockbuster, The Island. The second group watched Charlie Rose.
But more about the friendship. I mean, they were very different men. One loved the public eye, Taft didn't like the public eye. Taft was much more cerebral, would you say?
While the third group watched the same clip from The Island, but without the sound. Now, people who were watching The Island ate almost twice as many snacks, 98% more than those watching Charlie Rose. Even those watching The Island without sound ate 36% more. Researchers realized that more fast-paced movies have quick camera cuts, and that apparently distracts you from how much and what you're eating. Belly fat boosts a person's odds for high blood pressure more than overall body fat. While it's well known that obesity raises the risk of high blood pressure, up until now it wasn't really clear how the location of body fat affects that risk. Well, researchers tracked more than 900 people for about 7 years, and participants were checked for fat located deep in the abdomen between the organs, fat all over the body, and fat located on the lower body. Researchers found that only the abdominal fat, or what we may call our spare tire, was independently associated with high blood pressure. This link was present regardless of age, gender, or race. Last Thursday was the 13th anniversary of 9/11, when America was attacked by terrorists. As you recall, thousands of rescuers spent weeks and months at Ground Zero and at the Pentagon, and they are still feeling the physical effects of that day even now. Newsmax Deputy Health Editor Nick Tate is here with us to update us on a program that's actually helping people who are still impacted by that day. Nick, obviously it's a day that lives on in everyone's minds. The emotional impact, the mental impact is on these individuals who are the first responders, but now we're seeing that there's a physical impact as well.
That's exactly right, Lynn. You know, it's a startling figure, but nearly as many people who died when the towers fell have developed Ground Zero-related cancers and illnesses. That's according to the latest estimates. More than 2,500 first responders are seeking compensation, in fact, for cancer and other ailments that have been tied to the attacks, according to the CDC and the Mount Sinai World Trade Center Health Program that has been tracking them. That's about 1 in every 15 EMTs, firefighters, police officers, sanitation workers, and other city employees who were contracted to do some work in Ground Zero and now have World Trade Center related cancers. We're talking about things like prostate cancer, thyroid cancer, leukemia, multiple myeloma. Health experts believe, though, that those are not the only cases we're going to see. There are countless others who just haven't been diagnosed or have not been treated by the doctors that are affiliated with these government-funded programs, Lynn.
And is there going to be a program that will be around for the long term and be able to provide this long-term care?
Well, that's an open question. There is, in fact, a 9/11 victim compensation fund that's been distributing payments that range from a few $100,000 into the millions. But the latest figures suggest that much more money will be needed to help everyone, and that's an open question whether it will exist. So far, the fund has received about 1,200 claims listing cancer from first responders, local residents, and visitors. Most have been deemed eligible for compensation, but health experts say that it could be as many as 60,000 people who are at risk of developing these cancers and other deadly diseases from inhaling the toxic chemicals from dust and fumes at Ground Zero. And the question is when they will come forward and when they'll see compensation. There's a deadline of October 14 for applying for cancer claims through this 9/11 fund. So there's likely to be a last-minute rush for people filing claims as well as surviving family members. But there are surely going to be more cases in the future, since cancer can take, many years or even decades to develop, and whether the funds will be there remains to be seen.
Well, I'm sure that you'll continue to follow that story for us, Nick. Thank you so much. And of course, we will never forget September 11th. And once again, we pay tribute to those that were lost on that fateful day.
Oh, say, can you see by the dawn's early light what so proudly we hailed at the twilight's last gleaming?
Edward Bosco.
And my brother, hero, best friend, Sal Edward Thierry Jr. Your memory and my love for you will last forever.
And up next, we'll have two doctors who will give us their takeaway on Joan Rivers. Could her tragic death have been avoided? And what questions should the elderly be asking before any kind of procedure? That and much more when Meet the Doctors continues.
Miss Rivers, you had a girl. Good. Good. Is she normal? Yeah, good. Is she white? Yeah, good.
That was Queen of Comedy Joan Rivers, funny and snarky until the very end. As you know, she tragically died during what some have called a routine procedure. It was actually known as an endoscopy. But at the age of 81, how safe and routine is any procedure? That's what we're going to talk about during this segment. But first, we want to understand what exactly Joan Rivers was undergoing at the time of her death. For that, we're going to return to Nick Tate. Nick, can you explain to us what an endoscopy is?
Sure. Endoscopy is one of the most common procedures seniors undergo every year, with millions performed annually. Essentially, a doctor inserts a very small, flexible, tube-like instrument with a light and a camera at the end into the body to look for unusual growth, sometimes cancer, to see what's going on. It's also used in certain surgical procedures to give doctors a better view inside the body. Now, in Joan Rivers' case, we're told that doctors were doing some type of endoscopic procedure to either treat her vocal cords or to look at her vocal cords. So they would likely have inserted a tube down her throat to get a closer look. And of course, to do that, they would have needed to place her under sedation, which is one of the questions, and whether that put her at risk.
And that's exactly what we're going to talk about during this segment, whether going under anesthesia for an endoscopy or any kind of procedure should be something that should really be considered, especially for the elderly. Here to help us do that is Dr. Karen Patel, who is an anesthesiologist, along with Dr. Ian Lustbader, who is an internist and a gastroenterologist. Thank you so much for joining us.
Thank you.
Pleasure.
It was actually a doctor who is an gastroenterologist who was performing this procedure on Joan Rivers. Is it somewhat common, and is it unusual, in your opinion, to have a death associated with it?
So to some degree, only the people in the room know exactly what transpired, but an endoscopy is most likely what she had, a very common procedure, as Nick reports. We use it routinely to evaluate the upper gastrointestinal tract for acid reflux, abdominal pain, cancer, and often patients who have a change in their voice, a more raspy voice, by examining in part the vocal cords as you go down to examine the rest of the esophagus and upper GI tract. You can often see abnormalities, sometimes inflammation, vocal cord polyps. So often it's a very helpful exam, and it's a pretty routinely done exam.
Dr. Patel, I would imagine that this procedure is one that absolutely would have to be done under anesthesia.
Correct. It allows to relax the reflexes in order to allow the scope to pass, but also it allows for an awareness, and it helps manage any discomfort that the patient would experience.
What questions should we be asking, whether we're Joan Rivers' age or our age or younger, before we have anesthesia administered?
Right. Well, anesthesia is not an age-related all or nothing. You really want to know, it's the same questions you want to ask at any point. Where is the anesthetic going to be delivered? Is it in a certified facility? Are there board-certified anesthesiologists delivering the anesthetic? Are they supervising nurse anesthetist? And if so, how many anesthesiologists are on staff there, and how many nurse anesthetists are on staff? Is it possible for the patient to meet with the anesthesiologist the day prior to the procedure? And is that anesthesiologist asking about their medical history?
So again, we have to take control of our medical care and ask the right questions, make sure that the right people are in place. Absolutely. What if we have a known reaction, or if we've had a bad experience previously with anesthesia? Should that be noted to the anesthesiologist?
Absolutely. If you have had a difficult reaction or any type of reaction to anesthesia, or have what we call in the anesthesia world as a known difficult airway, that needs to be given to not only the anesthesiologist but the gastroenterologist who may be performing your procedure, because that's a significant concern. That may even change the gastroenterologist's decision to do the procedure in an outpatient setting or change it to a hospital setting.
And that's what I wanted to ask you, if these so-called freestanding clinics should be avoided, or typically if they can be as trustworthy as a known hospital or institution.
Typically, the ambulatory surgery centers or the outpatient endoscopy facilities, certainly in New York City, New York State, are inspected. They have to be certified. Often they're affiliated with hospitals, and often it's a more pleasant experience for the patient. So by and large, these are accredited facilities, very safe. But with any procedure, you always want to ask, why do I need the procedure? Are there any alternatives to the procedure? What are the risks to the procedure? How am I going to be sedated? What's the experience of the anesthesiologist who's going to be there? And certainly the anesthesiologist typically talks to the patient and makes sure that there are no contraindications to the procedure. But in general, when all of that's done, and generally all of that is done, we don't hear about this too often, it's a very safe and very positive patient experience by and large.
I was going to point out that probably we're talking about this because it was Joan Rivers who succumbed at this particular time. And again, we don't know specifically what caused her death. Is it possible that at 81, undergoing even what might be considered a routine procedure, that she just passed away and it wasn't because as a result of a fault of someone or a miscalculation with the anesthesia?
That's entirely possible.
It's possible, but highly unlikely. Generally, she was up, she was active. We don't know, and only her doctors know, did she have underlying heart disease or diabetes or some other contraindication? That would put a different spin on things. But based on her appearance and her energy, doing an indicated procedure at 81 should pose no significant risk. Again, in the right setting with a monitored environment with appropriate professionals and anesthesiologists. Usually that's pretty straightforward. There are some gastroenterologists who choose to give their own anesthesia. There are some facilities who don't necessarily use anesthesiologists. That's possible, but by and large, asking the right questions and selecting patients appropriately, it can be very beneficial.
What are some possible scenarios that could have attributed to the death of Joan Rivers?
So complications from endoscopies and colonoscopies, fortunately, are low, very rare. But there are a limited number of possibilities that do occur. I'm happy to chat with anesthesia, but certainly we see things like over-sedation. Occasionally we'll see vocal cord spasm where the airway can't be aerated because the vocal cords are at the top of the trachea. Sometimes, rarely, again, there's vomiting and aspiration. Sedation problems, low blood pressure. Typically, we love having a good anesthesiologist in the room because those problems are usually well managed by the anesthesiologist to allow us to complete the procedures.
Dr. Patel, could there have been a problem with the anesthesia that could have led to her demise?
It's always possible, you know. Unless you're the doctors in that room, you don't really know what happened or what played out. The other possibility is that, you know, when any procedure happens, it puts a stress on the body. And even though you may have a cardiac workup before a procedure or have a pass through with your internist or pulmonologist, there are still unforeseeable effects of that stress on the body that can cause the heart to go into cardiac arrest or to cause a further respiratory problem. And that's unpredictable before. And what we as anesthesiologists have is a system in place where if those unforeseeable things happen, we have a set kind of protocol in which we go into and how to manage them.
It would be possible, unusual, with a good anesthesiologist in the room. And let me just say, not all physicians use anesthesiologists, not all physicians use board-certified anesthesiologists. There is a school of thought that physicians, gastroenterologists should administer their own sedation, and there's some evidence and articles to that effect too. But in any case, if something does go amiss, if there are complications, it is great to have people expert in airway management to protect the airway, to respond quickly, to monitor the patient.
Dr. Patel, you mentioned that age really doesn't come into play with anesthesia. So what should we look for, regardless of our age, to make sure that we do get the right kind of anesthesia?
Right. There's not a specific age where anesthesia should be cut off. As we age, obviously, comorbidities or conditions, we tend to accrue more health conditions. And so having an awareness of what those health conditions are and how severe they are is really what you need to know when you're determining whether an anesthetic is safe or not.
Well, anytime I would imagine that you're dealing with the windpipe, with the esophagus, with the lungs, with your breathing passage, that you need to have the utmost of care taken in providing that care to you.
One of the questions patients do ask and deserve to answer is, what's your skill? How many procedures have you done? What's the backup? How are the anesthesiologists trained? If there's a problem, is there appropriate backup? And those are all important questions, and hopefully the right answers are there.
And hopefully our viewers will ask those very questions that you've given us answers to so that they can empower themselves to be good healthcare consumers. Thank you so much. We're going to talk to you later in the show as we answer some questions from our viewers. But right now we'll take a short break. When we come back, we're going to talk to a leading researcher on Alzheimer's and his latest cutting-edge study. Stay with us for that. Welcome back to Meet the Doctors. I'm Lynn Doyle. So what if there was a test that you could take at home that would tell you if you were a possible candidate to suffer from Alzheimer's disease? Would you definitely take it? If I were you, I definitely would. I know I'm interested in it. Thanks to our next guest, that may very well become a possibility very soon. Dr. Joe Verghese is the director of the Center for the Aging Brain, and he's also the division chief of geriatrics at Montefiore Hospital in New York City. Dr. Verghese, it's good to have you with us.
Thank you for having me.
This is an exclusive opportunity that you're providing to our Newsmax viewers here on Meet the Doctors. Tell us what it is that you've discovered that could be a way to determine if people have Alzheimer's.
So one of the biggest challenges facing us now is that there's a growing aging population, and there are many people at risk for developing Alzheimer's and other dementias. And one of the challenges is to find ways to diagnose these people as early as possible before they actually meet criteria for Alzheimer's, so that you can institute preventive measures. One of the problems with the current diagnostic methods are they're not easily accessible. They require either detailed cognitive testing, or you need to do neuroimaging studies.
Right.
Many years ago, when I was a researcher working in an aging study, I examined hundreds of older people. And one thing I noticed is if older people were walking slowly, when I looked at their cognitive tests, memory tests, I noticed that they were abnormal too. So this provoked me and gave me an idea that maybe we could use a simple signs such as walking to predict who would be at risk for dementia.
So seriously, you're saying that looking at a person's gait and the rate at which they walk could actually open the door for a neurosurgeon like yourself to find out if someone suffers or would potentially suffer from dementia? That's amazing.
Well, absolutely. Walking is quite a complex activity. So while clearly you can have most people slow down when they age due to problems like arthritis, you need your brain to function well in order to walk well, especially when you're walking out in the street, you're talking to someone, there's obstructions in the way that you need to be aware of. And if your brain's not functioning well, your walking suffers too. And that slowing of walking that occurs very early might be an early sign of dementias like Alzheimer's.
So we don't want to frighten people here who are watching the show just because, as you pointed out, we slow down a little bit, our hips might hurt, our back might hurt, we might have a little extra weight on. It's not that. It's coupled with having memory complaint as well that kind of sends up a red flag to someone like yourself.
Absolutely. So we've described a syndrome called the motoric cognitive rest syndrome. And you meet criteria for the syndrome if you have slow walking, which is common, but in addition, you do have to have memory complaints. Complaints of forgetting names or appointments or difficulty planning your shopping list. And if you have the combination of those two signs, then that puts you at risk of developing dementia, and you meet criteria for motoric cognitive risk syndrome. Recently, we just published results from a large study involving over 26,000 people from 17 countries, and we found that 1 in 10 older people meet criteria for this syndrome. And in this study, when we looked at people who met the criteria, they were twice as likely to develop dementias like Alzheimer's disease compared to people who walked normally and didn't have cognitive complaints.
So let's talk about the actual test that you would give to someone who you suspected could be potentially an Alzheimer's patient. We're looking at a woman who is walking, and it sounds like she's reciting letters from the alphabet?
Absolutely.
What is the purpose of this test?
So this is a more complex version of the test that we would use. For the motoric cognitive risk syndrome, all you need to get is somebody to walk a fixed distance. In this video, we're looking at this process in a bit more detail. So the sensor that you see attached to her forehead actually measures brainwave activity, and the map that she's walking on assesses various aspects of her walking, like how fast she's walking, how big her strides are. And you can notice that she's walking and reciting the alternate letters. She starts slowing a bit, but her performance is actually not too bad. Everyone slows down a little bit while you're doing this test, but if you either stop or if you lose your balance during the test, that's not a good sign. But for the motoric cognitive risk syndrome, you don't need to get somebody to recite letters. You just need them to walk a fixed distance, time them, and if they're walking slower, generally a value of less than a meter a second, then they're walking slow.
Tell me what happens when someone has taken your test and all indicators say to you this person is at risk, if not already developing Alzheimer's. What's the next step? What do you do then?
So we often see patients who meet this criteria. I practice at the Montefiore Einstein Center for the Aging Brain, and when we see patients like this who meet the criteria, the next step is to investigate to find out what's causing it. So is the slow gait caused by poor circulation to the brain? Is it caused by the earliest stages of Alzheimer's disease? What's causing the memory complaints? So we do a series of tests to identify the problem. And potentially this is a point in the development of dementia where you could actually intervene and arrest the process or at least slow down the process. We would also institute medications if necessary. There's no cure for Alzheimer's, but there are a number of medications that help with the symptoms. And we would also get them to have a healthy lifestyle, because having a proper diet, exercising, and doing cognitively stimulating activities, for instance, have been shown to prevent dementia or slow down dementia. So it's important to get these people to do these activities.
It must be devastating when you have to deliver the news or the diagnosis to a patient and the patient's family that, yes, in fact, it is Alzheimer's.
Yes, indeed. I mean, it's one of the saddest things I have to do. But, you know, the reassuring part is if I can identify somebody early, I could actually do something to alter the course of the disease. And once in a while, I actually do have patients who come to me with just slow walking or memory complaints, and I can happily tell them, look, you really don't have any problem. So I think the main message is if you do have the combination, you need to be checked out. It doesn't mean that you necessarily have a disease.
So I was just going to finish this conversation by asking you what you would say to the viewers at home, how they could implement this test, which is very non-invasive, and yet it needs to be administered the proper way so that we're not walking home with end result that is not necessarily Alzheimer's.
Absolutely. So I think it's a test that could easily be implemented at home, but it needs to be conducted in the right way. You need to have a fixed distance. You need to know what the values that constitute slow gait. But if you think either you or one of your loved ones is walking slow, and there's also you're noticing memory complaints or difficulty just functioning in daily life, this is someone you should bring to the attention of your physician and get them checked out.
Well, we certainly appreciate you telling us about it first and foremost. We wish you continued success with it. We are going to have some questions about Alzheimer's from our Newsmax viewers. Will you stick around and try to answer them for us?
Thank
We
you.
certainly appreciate that. All right, thank you so much. We will take a short break, but when we do come back, we will be talking with our panel of doctors, answering those questions that you want answers to first and foremost. So please stay with us. Meet the Doctors will continue right after this. It's that time of the show where we actually get to meet the doctors on Meet the Doctors, and they graciously answer some of the questions that you sent to us through our email. If you have questions and comments, we always like to hear from you, and we do our best to give you a generalized answer when we can. We are joined once again by Dr. Patel, Dr. Lusbader, and Dr. Verghese. So let's start. You guys ready? Okay, we have one, obviously, after that last segment that we just did, it generated a lot of questions, so I do want to start with you. Is there a way in our everyday lives that there's something we could do to ward off Alzheimer's, or is it predestined that if you're going to get it, you're going to get it?
Well, there are a number of things you can do to prevent the onset, or at least delay the onset of Alzheimer's. Most of these are common sense. A healthy lifestyle. There's been a lot of interest in Mediterranean-style diets, which are high in vegetables, fibers, and low in red meat. And people have shown that this prevents cancers, but in more recent studies, they've also shown that it's associated with reduced risk of Alzheimer's disease. An area that I'm really interested in is cognitively stimulating activities. So our studies have shown that people who engage in cognitively stimulating activities seem to be at reduced risk of dementia.
Does that mean like trying to do the New York Times crossword puzzle? Because if it does, I'm at risk.
There are even apps now that you can get that cognitively stimulate you, that whether you're working or interacting, you can still do a lot of things even while you're on your cell phone that may seem to reduce the onset of dementia.
Another reason to have our iPhones or our devices close at hand. Okay, I have another question, this one for Dr. Patel, who I should point out is an interventional pain management specialist. So this one seems like it might be perfect for you. It says, I'm suffering from a strange hearing problem. I hear what sounds like soft voices or wind in my ear. Could it be tinnitus, or is there some connection with high blood pressure? Do you have anything I could do to try to alleviate it?
So tinnitus can be caused by a number of things, and I often see patients who come to me with tinnitus as one of their presenting symptoms. They have neck pain, and they also they hear cracking in their neck when they're turning their neck, and their range of motion is restricted. And they often tell me they feel dizzy when they look up, and that they also have this high-pitched sound that they hear. And oftentimes I find that it's related to arthritis in the neck, or traumatic injuries in the neck and head that can cause damage to the hearing apparatus. Now that certainly is not the most common reason to have tinnitus. However, you know, the thing that most patients should think about is it in both ears or is it in one ear? Is there any history of trauma? And then that's the kind of stuff that I tend to see more often. But in general, the most common type of tinnitus is related to age-related hearing loss, and also related to ossification of the bones in the ears.
All right, this question comes from a viewer who says, milk and even water sometimes cause heartburn for me. What could be causing this? Do I have an ulcer, and what can I do about it?
So heartburn is very common. We see it in many patients. It can be caused by overproduction of acid. It can be caused by a hiatal hernia. Certainly we know there are a variety of foods that can worsen it. Fatty foods, fried foods, mint, chocolate. Conditions like pregnancy can worsen it. But typically drinking water you would think would dilute acid and wash it out of the esophagus, which it typically can do transiently if medications like acid blockers, Prilosec, Zantac don't work. But sometimes that water just merely dilutes the acid, overfills the stomach, and then it refluxes back up, and then water can actually seem to give heartburn. Again, that should be seen by a physician, a gastroenterologist, and more evaluated.
Is that heartburn a cause for many people to have an endoscopy, which we talked about earlier in the show?
Sure. Yeah, there's no question that that is a symptom that can be better evaluated by an endoscopy. Make sure there's no damage to the esophagus, Barrett's esophagus. Typically, we'll try simple maneuvers first, simple acid blockers, simple dietary maneuvers. If that doesn't work, then you need a further evaluation.
Okay, on that note, we have to take a short break, but we're going to have some more questions for you. You want to stay with us because you never know, one of your questions might be here on the show, or you might learn something from what our doctors have to tell you. Please stay with us. We're going to come back right after this. Let's get right back into answering your questions. That's why we're here, so that we can give you information so that you can empower yourself and be a good healthcare consumer. The next question says, I suffer every night from pain in my hip, my legs, and my upper thighs. Is there anything I can take for this? And do you have any idea, any speculation, what could be causing it? I'm going to go to my pain management here, my pain management specialist. Want to jump on that one?
Well, this is something that I hear all the time from patients who come into my office. And so it's really not so much the focus of the question, which is what can I take for this, is what's causing it? Mm-hmm. You know, it could be something as simple as arthritis, osteoarthritis, which is quite common. It could be a herniated disc, which is, you know, causing compression of a nerve, which is leading to pain in the back and the legs and the thighs. It could be another condition, is electrolyte abnormality. So it really begs more of an investigation.
As a neurologist, I deal with a lot of weird and strange diseases, so I'm quite used to hearing patients who can't describe what they have. But as a neurologist, you're able to piece together the information that they give you to identify a pattern, and then you examine the patient and put the history and the exam together to come up with the test to order and the management plan. So while there is going to be a natural worry about, can I actually talk to the doctor properly, I think it's more important that you overcome that and get tested.
Right, because it's obviously going to get worse if this viewer doesn't do something about it.
With what I do, pain management, we often see pain patterns where, you know, patients can identify that this happens every night and it's very predictable, but instead of masking the pain, we want to get to the source of it, to really try to break that pain cycle, the repetitive patterns of pain.
Okay. One last question. This is a yes or no. Does aluminum foil have anything to do with Alzheimer's disease?
No.
I'm so glad you said that. So we don't have to worry about whether we've wrapped our food in aluminum foil and that we're going to be predisposed to Alzheimer's. No. All right, good. Good news. Gentlemen, lady, thank you so much for being with us. And of course, we always thank you for being with us. Until the next time, we ask that you stay happy and healthy. For Meet the Doctors, I'm Lynn Doyle.